Welcome. We're going to talk with you today about the latest and greatest about what's happening with LSVT. New applications of LSVT LOUD, including pediatrics, swallowing, machine learning, and global impact. We are thrilled to be presenting this information to you today. So I am Dr. Lori Ramick. I am the Chief Scientific Officer for LSVT Global, as well as a co-founder. And I am here today with Dr. Jessica Galgano, who is a wonderful expert in LSVT Loud. And together we're going to share new information with you about LSVT Loud, both in the world of Parkinson's and also pediatrics, etc. So thank you very much for being here, and away we go. Our disclosures are included here, and we give you that information. Next. We are delighted to acknowledge the support we've had from for our research from the National Institutes of Health for many years, of 25 years, and other wonderful organizations. Without this support, we would not have been able to study and publish information about the efficacy of LSVT. So the prevalence of Parkinson's disease is expected to double by 2040. Up to 10 million people worldwide are living with Parkinson's disease. Are we going to be ready? 89% of patients with Parkinson's disease have a speech or voice disorder, and eventually everyone in the Parkinson community will have a speech and voice disorder. Even when James Parkinson, back in 1817, talked about speech and voice in Parkinson's, he said his words are now scarcely intelligible. The power of articulation is lost. And I want you just to think about that for a moment, because James Parkinson was a neurologist, and neurologists rarely talked about speech and voice disorders. But because the speech and voice disorder was so pervasive in Parkinson's, he talked about it, and this is very important. The primary perceptual characteristics of voice and speech include reduced loudness, hoarse voice quality, monotone, imprecise articulation, and vocal tremor. Vocal sound pressure level, or loudness, compared to Parkinson's and healthy controls, is one of the most significant negative variables. Parkinson patients are 2 to 4 decibels less than healthy control subjects, age matched across tasks. And what you see in this plot is on the vertical ordinate decibels of sound pressure level, and across the bottom, various speech tasks. Parkinson patients are in yellow, and healthy controls are in blue. And what you see is a statistically significant difference. So the bottom line is, even though older people talk more softly, people with Parkinson's disease are 2 to 4 decibels less than healthy control subjects. And that means people cannot hear and understand them. Does this problem matter? Here are some quotes from some of our patients. If I have no voice, I have no life. No one listens to me anymore. My struggle with my voice has been most challenging, caused me more heartache and frustrations. So, speech clinicians, these are the things patients are saying about the challenges in speech and voice in Parkinson's. We need to help them. Nick Miller has done a wonderful series of studies and concluded that these voice and speech disorders contribute to lifelong frustration, embarrassment, and social isolation. So these are really significant problems in the life of people with Parkinson's. Historically, speech disorders in Parkinson's were unresponsive to speech treatment. Wonderful clinicians worked very hard to improve speech, but in 1987, when we did our literature review, there was no effective voice and speech treatment for Parkinson's disease. So the reality is 89% of patients with Parkinson's have disordered speech. Back in 1994, only 4% received speech treatment. Today, on an exciting note, 2018, 45% received speech treatment as reported by a group in Sweden. So we're making progress, but we've still got a long way to go. So, 30 years, LSVT Loud has been working on invention to scale up. And over on the right, you see us climbing the mountain. And this is really important to recognize when you want to bring a treatment that's developed in a laboratory into clinical practice. It says here, on average, it takes 17 years for 14% of original research to be implemented into a physician's practice. So it's not a trivial matter when you develop a treatment, when you study a treatment, and then you begin to implement it into real life. So what you see in this chart, if we look along the left ordinate, phase 3, we did 3 and then 4 and 5 randomized control trials evaluating the efficacy of LSVT loud. That's really quite remarkable in relation to what has been done previously in the world of Parkinson's. And then our data analysis is ongoing. And then if you look at the bottom, phase 4 to 5, we are implementing LSVT loud in other disorders, pediatrics. Jessica will talk with you about that, as well as implementation in technology. And we'll talk more about that, as well as telepractice, which has really improved accessibility of LSVT loud to our patients. So our goal is not only do we study this therapy, publish the articles, but we want implementation in real world clinical practice. So today, LSVT Loud is considered the global standard for speech treatment in Parkinson's. Neil Pinto has published an article, and we have over 21,000 LSVT Loud certified clinicians in 78 countries and over 29,000 LSVT Big certified clinicians in 55 countries. LSVT Big is a physical and occupational therapy that is based on the principles of LSVT Loud. So, the goal of LSVT Loud is that patients use their louder voice habitually in daily communication, and there is long term carryover. This is not just something a patient performs in the speech treatment room. This is something they take home, they use with their friends and relatives at their office, etc. And your job as the speech clinician is to make that happen. The essential concepts of LSVT Loud are summarized here. Here's what makes this treatment unique. Number one, we have one target, which is healthy vocal loudness. Number two, the delivery of the treatment is intensive and high effort. The mode of delivery is intensive and high effort. And number three, oh my goodness. Anybody who's worked with people with Parkinson's knows the fact that patients do not believe they're too soft. They think their voice is just fine. And in order to get them to use a louder voice, we have to do what we call calibrating them, getting them to generalize that louder voice into daily living. And that's a huge step when we deliver LSVT loud. So we think about vocal loudness at two levels. Number one, the source, a carrier and signal transmission. So you listen to your television or your radio or whatever. You can't hear it, you turn up the volume. Okay, that's good. Makes sense. Now I can hear better. But that's not the only element in LSVT. What we've learned is increasing loudness is a trigger. It enhances effort and coordination across the motor speech system. Loudness is a global variable. And I just want you to take a moment and take pause at that, because what that says is when you ask somebody to get louder, they're not just getting louder, their whole speech mechanism is changing. And that's a huge reason that we hear improved intelligibility and better speech production when we train patients to increase loudness. And that took our breath away because when we first began doing LSVT, we kept thinking about the larynx and getting louder, and that's good and that's wonderful. But the idea that loudness is a global variable is huge. And I want you to embrace that. So here we go, the source and the trigger, cross system effects. So on the left, you see the soft talking Parkinson person, the respiratory system, the vocal cords, everything is diminished. And then we say, get loud, and oh my gosh, multiple levels of speech production change. Increased respiratory supply, vocal cord closure, mouth opening, etc. This is the brilliance of using loudness as a treatment target. So, not only does it enhance multiple levels of speech production, which is great, it improves efficiency of treatment. So, patients have to only think of one thing. Think when you're working with your patient and you want to improve their speech, you go, take a deep breath, open your mouth, have better articulation, have intonation, have better outcomes, reduce your rate. You don't have to do any of those things besides say to your patient, improve loudness. And all of those variables can have a positive impact. So, thus, it simplifies treatment by minimizing cognitive load. Instead of loading up your patient with five things they've got to think about, you're telling them to do one thing: improve loudness, improve healthy vocal loudness. So, what did we do? We did a model for clinical outcome research based upon the Roby and Schultz model. Phase one, if you're going to discover a treatment, you detect the presence of a therapeutic effect. What's the population? What's the protocol? What's the dosage? Then, phase two, you define and refine the protocol, measure the outcomes, valid and reliable measurement. Phase three, you do a test of the efficacy of treatment. This is the randomized control trial, which is the main way any treatment, not just speech treatment, but drug treatment, any treatment is evaluated to see whether or not it is efficacious. This is the gold standard of evidence. And we have 5 randomized control trials for LSVT. Then you say, okay, what about real world practice? So we move to expanding populations, other disorders, and other service delivery models. And you're going to hear from Jessica later about application to pediatric patients, and it's very exciting. And number 5, the goal is that this is implemented into standard practice. The treatment is generalized so that it is delivered in a standard way globally. And as I mentioned to you before, we have clinicians delivering LSVT all around the world. So we initially conducted 2 randomized controlled trials to test the efficacy of treatments to improve vocal loudness. We know this is among the first and most pervasive symptoms in Parkinson's disease. So we had 2 forms of treatment: high effort respiratory treatment and then high effort voice treatment, which became LSVT. We studied 45 patients and we actually studied them out to 24 months follow up. Then we did a second study where we compared LSVT to untreated control groups, Parkinson's disease and healthy, and we studied 44 patients out to 6 months. So the initial randomized control trials to test the efficacy were novel. Back when we did them, nobody did intensive dosage. Nobody did 16 sessions in a month of high effort treatment. Nobody focused on one variable of loudness, a single treatment target to enhance visibility, and nobody worked on the sensory feedback in Parkinson's. So I need to say very clearly these 3 elements were unique and very exciting and allowed us to document the fact that this treatment could work and last in Parkinson's. So here we have a plot on the vertical ordinate, decibels of sound pressure level, and on the horizontal, we have time. So LSVT is blue, respiratory treatment is red, and what you see very importantly is that pre-treatment, both treatment groups are the same in terms of decibels of sound pressure level. That's very important. And you see with the little red star, only LSVT had a statistically significant increase pre to post treatment. And if you go to the end where it says 24 months follow up, only LSVT maintained that treatment effect. So hold your breath here. This is the first time any speech treatment in Parkinson disease has been documented not only to improve speech treatment pre to post, but to maintain it 2 years after treatment. This was published in the Journal of Neurology, Neurosurgery, and Psychiatry, and it was considered level 1 evidence by Christopher Getz and his colleagues. So now let's take a look at a patient. This is a 59-year-old female. She's 2.5 years post-diagnosis, so quite early. She's on her medication pre and post, and she's pre-post LSVT loud. Take it away, Shirley.
Have you noticed any changes in your speech or your voice that you would associate with Parkinson's?
Yes, I don't speak loud enough a lot of times.
Anything else?
Hoarse.
Uh-huh. Anything else?
I stutter, which I never did before.
Do this for me if you would. Take a deep breath and say ah for as long as you can.
Ah.
Good for you. Okay. Would you say Parkinson's disease has caused you to talk less?
Yes,
Because?
because I stutter and then I can't be heard. If there's noise in the house, like when the kids come over, nobody pays attention to it because they can't hear me. Till I get mad and then yell.
Take a deep breath and say ah for as long as you can. Have you noticed changes in your speech or your voice as a result of the speech therapy?
Oh yes,
What have you noticed?
I talk louder. I think louder. I'm going to sing with the Sons of the Pioneers one of these days with my voice.
Good for you. That's excellent. What practicing do you do at home?
My ahs, my highs, and my lows. And I read out the mail out loud.
Excellent. Do you feel like practicing helps?
Oh yes.
Okay. Do you feel as though people can understand you all of the time now?
Majority of the time, unless it's my husband, and he'll say, "What? I can't hear you."
Good for you.
But I think he does that just to be cute.
I think he does too. Has anyone commented that it's easier to understand you now?
Oh yes, I set some of our friends back when we went to their house and I talked loud. Lou says, "What the hell happened to you?" My daughter said, "Oh, Ma, that's you?"
Isn't that good? Don't you feel wonderful?
Oh yeah, because now she can't say, "I didn't understand what you said."
Right? No excuses, right?
Yeah,
That's
no
right.
excuses.
All right. So what do you do when you want to be as easy to understand as possible?
Think loud.
Okay, that's pretty remarkable, isn't it? And Shirley is not a random person and the best person we've ever had. She's a pretty typical patient after LSVT. Now, not only did you hear the loudness increase, but you saw the changes across her whole speech production system. And that's what you need to embrace as speech clinicians doing LSVT loud. It's not just about increasing loudness. It's changes that occur across the whole speech production system that brings the voice alive. And you could see the changes in her facial expression, articulation, all of those variables that we have measured in our research. Shirley is an inspiration, and I encourage you to be inspired.
Have you noticed any?
So, improvements in loudness, voice quality, intonation, overall impact on functional communication, facial expression, and confidence. That's the other thing. Oh my gosh, patients are empowered when they are given newfound control over their Parkinson disease symptoms, and you, the speech clinician, can make that happen. So, back in the day when I first met Mrs. Lee Silverman, 1987, her family said, if only we can hear and understand her. So, the foundational evidence for the value of intensive voice treatment in Parkinson disease motivated our current work. So, that was the foundation. From that time, there have been biological bases of exercise in Parkinson disease, identifying principles of activity dependent neuroplasticity. Treatment science has advanced. The consort guidelines are very strict rules about whether or not treatment evidence is useful. And studies rated on qualities as random allocation, concealed allocation, baseline comparability, well-trained assessors and analyzers, intention to treat analysis. The point is, evaluation of the quality of treatment is very important. And LSVT matches all of these criteria very, very well. So, the most recent randomized controlled trial implementing consort guidelines was designed to address, is it the target of treatment or intensive dosage that maximizes treatment effects in Parkinson's? So, we recognize that we've given the treatment in intensive dosage. Is it the fact we're focusing on loudness, or if we focused on something else, would that be different? And so we did a study with well-defined treatment protocols with two different targets: vocal loudness, LSVT loud, and speech articulation, another challenge people with Parkinson's have, and they were delivered in an identical intensive mode. So we had 84 subjects, 4 groups. 2 groups received intensive treatment, LSVT loud or LSVT artic. 2 groups remained untreated, Parkinson's and healthy non-Parkinson patients, and they were used in a sample size of 20 with a statistical power of 0.80. I'll show you the data from 3 Parkinson groups here, 64, and they were all comparable on subject characteristics pre-treatment, age, stage of disease, etc. So here we go. Starting at the left, we enrolled 64 subjects with Parkinson's. Pre-treatment, they were assessed by neurology, ENT, neuropsychology, swallowing, speech lab, and then they were stratified and randomized into treatment groups. All of them received 16 sessions of treatment in 1 month, daily homework, and carryover all 30 days of the month. Post-treatment, they had the same assessment, including swallowing. And then for 6 months, they had no treatment, but they were encouraged to practice. And then at follow-up, their data were collected at 6 months. So the select dependent variables, the single primary outcome variable for this randomized controlled trial was decibels of sound pressure level for a reading passage and a 1-minute monologue. The secondary outcome variable was the modified communicative effectiveness index, and this is a self-rating. And then we've gone on to do evaluations of speech intelligibility, as well as voice quality. So let's look at monologue. On the vertical ordinate, it's decibels of sound pressure level. And what you see is pre-treatment, all the groups were the same, which is very important. And when you look at the solid black line, LSVT loud, that's the variable that had a significant increase in sound pressure level in 60 seconds of monologue. The data from the LSVTR tick also increased, but you see it's much less. But nevertheless, there was an increase in sound pressure level. And the untreated Parkinson patients had no improvement at all. And what's of great importance is when you look at the 7-month um, data plot, you see that only LSVT loud had a statistically significant maintenance in terms of changes in the decibels of monologue at 7 months follow-up. And here we have the city, which is the self-rating. And what you can see is both LSVT loud and Arctic have little red stars indicating that they improved in their self-perception after treatment, but when you go out to 7 months, only LSVT loud maintained that difference. So why is this important? It's important because it says that the patients believed they were improving pre to post treatment, and that's very important. This is not a biased study. The patients believed they were improving, but they did not maintain that improvement out to 7 months. And so that's an important difference and speaks to you as a speech clinician in terms of your impact on these patients. So the summary of the third RCT, LSVT loud had a greater degree of improvement on the primary and secondary outcome variables when compared to LSVT tick, and the only lasting improvement. So the source and the trigger, cross-system effects. The single target of loudness impacts multiple levels of speech production, and that's what's so brilliant about loudness. So you see, you cue your patient to improve loudness, and changes occur across their entire speech production system, which allows us to observe all of these changes. I love this slide because it tells us what we've studied over the years. We have done 5 randomized control trials. We've studied 174 participants, and beyond efficacy, we've looked at changes across the speech mechanism. So just for fun, let's start at the bottom on the left side and walk up all of the articles we published. EMG, electromyography with collaboration of Eric Lushai, aerodynamics, subglottal air pressure, maximum flow declination rate. Moving up, vocal cord adduction, published with Marshall Smith, documenting improvements in glottal closure. Swallowing, early studies with the work of Jerry Logeman and her colleagues. And at the top, we have now done 3 brain imaging studies of what's happening in the brain of these patients. Now let's go over to the right and slide down. And Jennifer Spielman and Joan Borad did facial expression, and you saw those changes in Shirley. Our colleague Erica Levy, as well as Geraldine Schultz, have done articulation and intelligibility studies following LSVT. Shimon Sapir has done articulatory acoustics. We have done vocal intonation. Ann Smith has done speech motor stability, and we've done voice quality. Jenna Moya Gale has published in the Journal of Voice, and the perceptual impact. So loudness is one target that makes an impact across the entire speech production system. And we have measured and published on these variables. Very, very powerful and very exciting, and motivates us to say, is this going to help other patients with other disorders? So one of the key things, the underlying mechanism of reduced loudness, we know patients with Parkinson's have glottal incompetence, vocal cord bowing, and David Hansen many years ago published on this in looking at rigid scope viewing, and we published with our good friend Marshall Smith on flexible scope and what happens in these patients pre to post treatment. So pre-treatment, we can see a conversion glottis, lack of glottal closure. Post-treatment, we hypothesized better closure, better medial edge, not only improve loudness, but also improve quality. So let's take a look at some vocal folds.
Okay, again.
Okay, so we see really clear vocal fold bowing,
Good.
lack
Now
of
try a
vocal
loud
fold
one.
closure, which results in a soft voice, and
Nice
now
loud one now.
post-treatment, increased glottal closure,
Good. Again.
better loudness, and better voice quality. And what's hugely important is the fact that the changes with increased loudness are the same as you would have in increasing healthy loudness. So there's no strain, there's no hyperfunction. This is really, really important. And when you're in LSVT training, you will hear about ways to be certain you increase loudness in a healthy way. Okay, and what we have here is some data from an article published by Marshall Smith et al. On the vertical ordinate is glottal incompetence, and across the horizontal is pre to post. LSVT is blue, respiratory is red, and what you can see is blinded raters' viewing of glottal incompetence improved post LSVT. This is very, very exciting, and it speaks to the fact that we improved loudness and we have a physiologic reason for that improvement. It's improved glottal closure and it's not hyperfunctional. And these data were published in the Journal of Voice. So now let's ask some very exciting questions. Can voice treatment improve real world listener ratings of speech, intelligibility, and voice quality? So we have this poor patient and no one can understand him, and we're trying to get him louder. Is it going to help to have people understand him? And the answer is yes. We had a study that we did with Dr. Erica Levy and her team to test the hypothesis that intensive speech treatment improves intelligibility in people with Parkinson's disease in a randomized controlled trial. Blinded listeners, 117 orthographically transcribed one sentence from speakers' self-generated speech, and the primary outcome was pre to post change in transcription accuracy, which is the standard for measuring intelligibility. So what we see on this ordinate is the vertical ordinate is percent of words transcribed accurately, and across the horizontal we see time, and the solid blue is voice, the dotted is articulation, and the green is no treatment. Between group differences from baseline to post in transcription accuracy indicated significantly greater increases following LSVT LOUD than following LSVT RTIC. And I just want you to hold your breath for a moment on this outcome. Number one, people have always talked about how important articulation is to intelligibility, and it is. And no one has thought about, what about loudness? If you're not loud enough and you're not audible, are you going to be intelligible? Well, we dug into that, and the bottom line is what we found here: increasing loudness has a more significant impact on intelligibility than increasing articulation. And this is in Parkinson's disease, mind you, but it's hugely important because articulation has always been the reason that people think someone's not intelligible. But guess what? If you're not audible, like you aren't in Parkinson's, you're not intelligible. And these data really speak to that. Okay, thank you. So now we have a really cool study using crowdsourced listener ratings. What does that mean? That means you grab speakers or listeners who, sit at home, they don't know anything about Parkinson's. They just get on their computer and they rate voices of patients with Parkinson disease. And the bottom line is when they do that, these individuals who are not trained in Parkinson's, who are off the street people, listen to people with Parkinson's before and after their speech therapy, and they're able to hear differences. So what does that say to us? It says to us that what we're doing in speech treatment makes a difference to off the street individuals. This paper was published in the Journal of Speech Language Pathology. It's a wonderful paper led by Tara McAllister. And on the next slide, you will see the plotting of the data. Patients rated more clear pre compared to post on two different words. And the bottom line is it says to us that individuals who are not trained in listening to people with Parkinson's and they simply rate what they hear online on their crowdsourcing mechanism are able to hear improvements following treatment. What that tells you as a speech clinician is the work you're doing with patients not only makes a difference in your hands, in your research lab, with patients' family members, it makes a difference out on the street when they're talking to random people. That's hugely important. Now, here is another fabulous paper that was recently accepted in the Journal of Speech Language Hearing Science, and it's a scatter plot showing the typical voice quality ratings compared pre and post treatment. And what this also supports is the fact that individuals who are not trained in our world, but nevertheless are listening to individuals with Parkinson's disease can hear a statistically significant increase in their improved voice quality following treatment, which is very exciting. So here we have the healthy controls, the ARTIC group, the LOUD group, and the untreated Parkinson patients, and you can see the changes occurring. So why is this important? It's important for you as a speech clinician to recognize that when you're treating these patients, you are making an impact on their life outside of the treatment room. And that's amazing. So what about AVQI in people with Parkinson's? This is a voice quality measure. Jenna Moyo-Gale looked at this variable, published it in the Journal of Voice, and looked at how voice quality changes. We think about we're improving loudness, we're improving articulation. What about voice quality? And so that's what Dr. Jenna Moyo-Gale studied. And the data were published in the Journal of Voice. And here we have them. AVQI, which is a wonderful measure of voice quality. On the left, in the middle is sound pressure level, and at the end is SPL, maximum phonation. And basically, healthy control, untreated, LSVT ARTIC, LSVT LOUD. And what you can see is a significant improvement in AVQI, which is a measure of voice quality that corresponds to the increase in sound pressure level as well as SPL maximum phonation. So what about brain changes? Oh my gosh, how exciting is this? And so we've been so fortunate to collaborate with a group in San Antonio. Recently, we actually got a cover in the Human Brain Mapping Journal led by Shalini Narayana. And the study compared acoustic and neural changes accompanying treatment, LSVT loud, and articulation matched in dosage. And 19 participants were randomized into 3 groups, and the severity of dysphonia was assessed by the spectral peak prominence. So subjects were comparable. And the therapeutic effects of intensive dosage augments the activity in the feed-forward system for both voice and articulation. The target specific effects following voice treatment are mediated by greater activation in the feedback subsystem of the speech motor network. So what does that mean to you as a speech clinician? What it's saying to you is, yes, both treatments were effective. Both treatments had an impact on various aspects of neural functioning, but the LSVT that focused on the neural changes in the auditory cortex had the most significant impact. And that's the calibration that you do when you do LSVT loud. These are absolutely thrilling findings, and I encourage you, if you're interested, to take a look at them, because what it says to you is what you're doing in speech treatment has a neural foundation in terms of the impact. So we can have all these wonderful, wonderful research findings, but we're in love with our patients. And so to a patient, there's a major life impact. My voice is alive again. I can talk to my grandchildren. I feel like my old self. I am confident I can communicate. Now, LSVT beyond Parkinson's, here's a listing of articles. And again, it's important to recognize these are not randomized control trials. They may be single subject case studies, small group designs, but they're all published and they're all supporting the fact that LSVT loud can have a positive impact on atypical Parkinson disease, post-DBS, stroke, multiple sclerosis, ataxia, cerebral palsy, Down syndrome, autism, and aging. And we have had collaborators all around the world publish articles demonstrating the value of LSVT in their language. And here we have a listing of German, Japanese, Cantonese, Mandarin, Spanish, Persian, Italian, Turkish, French, Portuguese, etc., all documenting the positive impact of LSVT loud. So one of the new adventures we've begun is looking at Parkinson's and swallowing. And we recognize that swallowing problems are very common in Parkinson's. And we began a study years ago with Dr. Jerry Logeman, and unfortunately she passed away. And so we've begun to look at those data, and we're looking forward to looking more at the data. Options for problems include muscle rigidity, muscle weakness, sensory deficits, hypokinesia, and bradykinesia. And so we compared LSVT loud and LSVT artic, keeping in mind very, very carefully that neither of these treatments were designed to improve swallowing. They were designed to improve speech and voice, but not swallowing. But the bottom line is we had feedback from LSVT loud clinicians saying to us they saw improvements in swallowing. So we wanted to do a very preliminary investigation. So these are the potential impacts. Voice treatment, we improve vocal cord adduction, could impact swallowing. Pitch range could impact laryngeal elevation. Effort and coordination could impact swallowing. And so the idea is it wouldn't be unusual if we saw some improvements in swallowing. So we wanted to begin to look at that. So here's one study that was published by El Shakari et al. In 2002 with Dr. Logeman. Oral transit time on the vertical and across the horizontal, we see the milliliters, and we do see some improvements. And oral residue percentage, also we see some improvements. And oropharyngeal swallowing efficiency, we see some improvements. So again, I really want to emphasize these are very preliminary findings, but nevertheless, they are encouraging in terms of moving forward. So we then looked at a blinded clinical review of data from a speech pathologist and looked at what we saw pre-post LSVT loud and LSVT artic. So let's have an example of an 85-year-old male, 1 year post-diagnosis, stable on medication, on meds as Hoehn-Yahr 2.5.
Swallow now. Trial 1. Sip from a cup. Okay. Swallow now. Trial 2. Sip from a cup. Thin liquid. Okay. Now, trial 3. Sip from a cup. Thin liquid. Swallow now. Trial 1. Sip from a cup. Swallow now. Trial 2. Sip from a cup. Swallow now. Trial 3. Sip from a cup.
Okay, so we're beginning to consider how LSVT may impact swallowing. And we're hoping to collaborate with some very expert swallowing researchers to help us design a study that can evaluate that very important question. So here are some preliminary data. You can see consistencies and volumes, artic in red, loud in blue, and untreated in green. And this is the penetration aspiration scale, documenting some improvements. But again, these are very preliminary. And residue results, exactly the same, artic in red, loud in blue, and untreated in green. And again, documenting to you that there may be some preliminary changes pre-post LSVT and the fact that we have a contrastive treatment with LSVT artic. So it helps us develop our next phase of research. And more residue results. So future directions, it's exciting to see that intensive speech treatment could influence swallowing. Where do we go from here? Larger number of subjects, more severe swallowing disorders, multiple raters, and investigate the mechanism of change. I think we can all agree that this question is an important one. We simply need to, not simply, we need to design a study with high quality measures, asking questions that address exactly what we're interested in relation to, does LSVT have a positive impact on swallowing? So another thrilling study that we're doing is funded by Amazon, Apple, Google, Meta, and Microsoft. And we're looking at the way to improve speech accessibility. When patients use various automatic speech recognizers, it's hard for them when they have Parkinson's disease to be heard and understood. So these technology companies are funding the ability ability of us to study patients with Parkinson's to train their speech recognizers to be able to improve recognition in Parkinson's. And we're in the heat of doing this study right now. We would love it if you refer us patients. This flyer that's on your PowerPoint has a link that you can sign up, have your patients sign up. We're looking for Parkinson's, MSA, PSP, CBD, and post-DBS patients. And it's very exciting. We did a study a year ago with Google, and patients loved it. All they do is sit at home, go onto their laptop and read sentences or phrases. And those phrases go on to these companies that then learn how to improve speech recognition. The patients can earn up to $180. The caregivers can earn up to $90. It's a very exciting project. And if you have patients who would be interested, I would encourage you to suggest to them that they participate. It's very cool. So thank you for walking up the mountain of development and dissemination of speech treatment in Parkinson's disease. Never in my wildest dreams did I ever imagine we would be where we are today, and it's absolutely thrilling. And a huge piece of that is you, because you're out there improving quality of life in patients with Parkinson's disease by delivering LSVT LOUD. So I thank you very, very much. And we've got more work to do. Away we go. And now I'm going to show you Shirley 8 years after LSVT LOUD. You saw her at the beginning. Now here she is 8 years later.
Did you find the speech therapy beneficial?
Very.
What were the changes you noticed right after speech therapy?
My voice was stronger and it was louder.
What % of your speech do you think is intelligible? That is to say, people can understand you.
100%.
And we said you've been practicing. How often do you practice?
Oh, about 5 times a week.
Do you really? Surely.
When I don't have nothing to do, I just sit in the chair and go, ah.
That is phenomenal. And have you done that like ever since we ended speech treatment? So do you feel like practice helps?
Oh, yeah.
Oh yeah. Let's do one more. Any great pearls of wisdom you have to offer the world, Shirley, about communication and Parkinson's disease?
Well, if you don't talk loud, nobody wants to hear you. They won't strain themselves. So you have to talk loud to be heard. And once you are heard, everybody wants to talk to you.
Okay, so thank you for listening. And now I'm going to turn you over to Dr. Jessica Galgano, who's going to open the door to an amazing topic, intensive therapy for pediatric populations. Take it away, Dr. Galgano.
Well, thank you, Dr. Ramick. What a wonderful presentation, and how exciting it is to hear about all of the latest and the greatest. So as Dr. Ramick mentioned a few moments ago, my name is Dr. Jessica Galgano, and I act as one of LSVT LOUD's faculty instructors and clinical experts. I've been administering LSVT LOUD to people with Parkinson's and both children and adults with other neurologically based voice and speech disorders for almost 25 years. I have really found LSVT LOUD to be one of the most valuable treatment programs out there. It continues to inform and transform the day-to-day clinical practice of both myself and the clinicians I work with. And today I'm excited to be here with you to introduce you to the application of LSVT LOUD to the pediatric population. So you might be thinking, well, wait a second here. How can we go from Parkinson's to pediatrics? And I want you to think about the perceptual characteristics that many children with neurologically based speech disorders have that are also consistent with the perceptual speech characteristics of Parkinson's, such as a breathy and rough vocal quality, or other quality changes, a monotone pitch, difficulty controlling rate of speech and rhythm of voice, imprecise articulation and reduced intelligibility. And like adults, communication is important. In fact, when Doctors Fox and Boliak interviewed families throughout their research, they found several common communication themes focused on verbal communication. There were consistent reports of wanting to be socially accepted, and children's first choice is to use oral communication and to continue to communicate orally, even in the absence of success. Children and parents also reported feeling extremely frustrated when peers or adults failed to wait to understand the child's message and simply walked away. So there is a great need. Now, with this understanding, the research team began looking into two different rehabilitation and habilitation approaches that have been found to be efficacious in pediatrics. And the team identified several physical therapy approaches for children with CP and Down syndrome that children often benefited from. Effective approaches for children with CP involve treatment programs with intensive frameworks. And in these frameworks, the number of sessions, the specificity of training, and a hierarchical approach that increased task difficulty over time all mattered. And in the Downs population, similar observations were made. Effective physical therapy treatments were those that involved treatment that took place more than once a week and showed that children with Downs absolutely can handle intensive and physically difficult interventions. Now, at that point, the team was motivated to ask, well, what about speech therapy? What about speech treatment? And at that time, they found that most speech language pathologists who specialized in pediatric motor speech disorders agreed that intensive motor speech treatment, regardless of the subsystems targeted, is the preferable mode of delivery, because intensive formats resulted in significant improvements that lasted for their pediatric patients with motor speech disorders. So this was a great opportunity to explore whether the intensive LSVT LOUD treatment approach would be feasible and have a significant impact on speech outcomes in the pediatric population. So back in the 1990s, Dr. Fox began applying LSVT LOUD to children with CP, and the results were really promising. So the first child she worked with was 3 years old and 11 months. He was a male. He was diagnosed with cerebral palsy at birth, a dyskinetic type that involved all 4 limbs, and cognition was normal, though he did present with some delayed language development. So let's listen to his pre-treatment speech and voice characteristics. Okay, so you could hear that this little one had a throaty quality. He had strain in his voice, limited respiratory support. Sometimes you might have heard that breathiness, variability in vocal loudness, and severely reduced intelligibility. You may have also heard that strain and just that breathy vocal quality that really impacted overall intelligibility. Now let's listen to him 1 month post-treatment. I don't know. I just love hearing that. I hope you all heard that improved stability of phonation, increased frequency of voice or higher pitch, louder voice. He wasn't so breathy. He wasn't so strangled or strained in his quality. His mother had said that he understands using his voice and knew what that means. And as Dr. Ramig mentioned earlier, as they see or the researchers saw in the Parkinson's population, we saw this as well in this little child, increased confidence with speaking, a very, very important result of this program. So with those results, and after piloting several others, Doctors Fox and Boliak found that the voice may be a good point of entry or a way for children to establish a foundation for speech production through intensive voice treatment. Now, you've already heard from Dr. Ramig about the essential concepts of LSVT LOUD, and I want to point out that the focus on amplitude not only applies to voice and speech, but it also applies to movement. And LSVT Big is the intensive treatment program that PTs and OTs use for children with neurologically based movement disorders as well. Now, the target of treatment is always increasing amplitude of movement. And for speech language pathologists, we target amplitude in the respiratory, voice, and the upper articulatory systems to enhance many levels of speech production and both improve the efficiency and simplify treatment. And this resource demonstrates how we work with amplitude in many ways within LSVT LOUD to address the speech motor disorder secondary to a wide range of movement disorders. LSVT LOUD not only targets increasing amplitude of movement to improve vocal loudness, size and speed of movements in hypokinetic dysarthria, but it also drives healthy amplitude to improve and stabilize speech motor movements needed for individuals with spastic, ataxic, and flaccid dysarthria. And as Dr. Ramig mentioned, amplitude acts as a trigger to increase movement across the entire body. So within LSVT LOUD, the clinician shapes and models normal loudness with a healthy vocal quality. Within LSVT Big, the clinician models normal amplitude of movement with healthy quality. And this modeling of normal movement in the speech motor system increases breath support, mouth opening, intonation, articulation, speech rate, facial expressions, naturalness in production, and more when we're increasing the amplitude across the entire body. And PTs and OTs are seeing better trunk rotation, stride length, speed, balance, coordination, and all of this translates to improved function in children's activities of daily living. But if we simply targeted increasing amplitude or stabilizing healthy amplitude with a low frequency and a low dose mode of treatment, we would not have the same impact of lasting results. So our mode of treatment must be intensive. It must be high effort, both within and across treatment sessions. And when we target amplitude to achieve that spreading of effect or improvement across the entire motor speech system, we can achieve our goal in therapy. And this is to incorporate multiple principles that drive neuroplasticity, including intensity, complexity, repetition, salience, timing, and specificity. And this treatment-dependent neuroplasticity occurs in the pediatric context when our treatment sessions have intensive task repetitions, progressive challenges to the learner with increasing difficulty, presence of motivators and rewards that are internally driven versus externally motivated, active participation and motivation towards tasks and goals, skill acquisition of functional goals, and practice must be structured. Now, we have to ensure generalization of learned behaviors as well. So these things will translate to a child's day-to-day function by focusing on what we call calibration and address those barriers that get in the way. So of course, we focus on function to ensure that calibration, ensure that carryover to functional environments. And to do this, we use materials and dual tasking activities that are salient or meaningful to the child across all levels of the hierarchy, within treatment and in the homework and carryover exercises that we design daily as well. So let's take a look at a video. This is a total treatment video clip of a little girl named Katie. She was 6 years, 7 months old, and had a diagnosis of spastic quadriparesis secondary to cerebral palsy. The parent reported speech and voice concerns like not taking a big full breath, not always having enough breath, stopping in the middle of sentences to catch that breath, and breathing in coordination. 2 speech pathologists that had looked at Katie noted variable loudness and pitch, an inconsistent and strained vocal quality, especially at the end of sentences, mild loudness or reduced loudness, and imprecise articulation. In terms of the dysarthria type, it was spastic with a moderate severity. So let's take a look at Katie during this treatment. And this is during week 4 or that last week of the intensive protocol.
Oh, perfect, Miss Katie. So what we're going to do is you're going to give me a nice big ah. Ah. Whoa! What did you get?
I got 953.
Good. Are you ready with your big, beautiful voice?
Yes.
Okay.
Hello, this is Katie.
Perfect.
Good morning. Stop it. Okay. Yes, please.
Don't forget to breathe.
Mom, Dad, come in here. Can I wake up? Stacy, thank you. Excuse me.
Okay, what if they didn't hear?
Excuse me.
Good. All right, now with your ah, let me hear another little ah. Go ah.
Ah,
Good with that voice. Explain what that is.
this is something you cook with. And it has different buttons that you can push.
Oh, try that again.
It has different buttons that you can push.
Good.
Microwave.
No.
No.
Stove.
Yes.
Woo! Good.
All right. So you could see there that Katie was definitely enjoying and having fun during this session. You could see Dr. Fox had used different motivators and ways to watch for loudness in spontaneous speech when that ah exercise was over. And she used cues to use that voice to be loud, to be strong, to be big. Using a cue that works best for the child, but striving that same motor goal for increased vocal loudness to achieve that spreading of effects is key. You could see Dr. Fox did not let soft speech slip by. She always had Katie request, or she had Katie repeat that voice or that speech with a louder voice. And the intensity of motor practice, even with a child this young, was easy to follow through with. Katie was really focused on that intrinsic motivation to do that activity. Calibration comments included, do you hear how good that voice sounds after those ahs? Use that. I love hearing that big, beautiful voice. That's the voice that's going to help you train your dog, for example. And saliency is going to be the key in these pediatric sessions. So it's just a joy to see the kids having fun, generating increased vocal loudness, increased vocal intensity, and having really no problem with this intensive vocal or respiratory voice protocol. Now, the second population that was most researched in pediatrics for individuals with a neurologically based motor speech disorder was children with Down syndrome. And there are many speech characteristics of those with Down syndrome that greatly reduce speech clarity, even when the treatment has improved articulation and phonological skills. Vocal quality is generally poor. Many individuals will present with changes in vocal quality, and children may sound rough in their quality, strained, or even breathy. Now, other times, due to unique anatomical or physiological profiles, resonance can be changed as well. They might be hypo or hypernasal, Pitch variation can be difficult, and impaired prosody is usually evidenced by difficulty controlling speech rate and rhythm. Equal stress across syllable and word boundaries is also often seen. There's also a high rate of motor planning and fluency disorders that persist into adulthood, and some research indicates that it takes those with Down syndrome 2 times the effort to initiate voice due to these anatomical and physiological characteristics. But what's really wonderful is that children with Down syndrome benefit greatly from intensive treatment. So let's take a look at a session now. What we're going to see is that this was conducted by a therapist in Colorado, working with a little cutie named Ajax with a telepractice or LSVT LOUD session.
My turn. Your turn, Ajax. Nice and loud. Nice job, Ajax. All right, let's do it again. Woo, your turn. Loud.
Loud.
Nice job, Ajax. Just like me. Your turn. Nice job, Ajax.
Okay, what an adorable little kiddo. So what we're going to see next is another session with Ajax and his therapist, bringing that treated voice, or the voice that's supported by that improved breath support and that stronger, healthier phonation, into functional speech exercises within the hierarchy portion of LSVT Loud.
Where are we going to go grocery shopping?
What's that? Where is that?
We're going to go grocery shopping at Whole Foods. Yeah. Can you say that one just like me? Nice and loud. Whole Foods.
Nice and loud.
Nice job. Let's see. Can you tell me to pick one? Pick one, please. Let's see. What did we find first? Oranges. Nice job. Orange. Nice job, Ajax. All right. What's next? What do I do? Okay. We're grocery shopping. We need more fruits. Nice job. That was nice and loud. Can you do it again with me? Banana. That was great. Nice and loud.
Please.
All right. What should I do? I'm grocery shopping. Okay. We need some more fruits. Oh, can you tell me nice and loud? Apple. Nice job.
Okay, so let's take a look at Ajax's results following the LSVT Loud program. He achieved many wonderful outcomes, including improved clarity of speech, improved speech skills when using his LSVT Loud voice, including using a slower rate of speech with multisyllabic words and longer phrases, more accurate articulation, self-correction, and improved focus on his conversational partners. So I love seeing and hearing about that spreading of effect to language that we often get from teachers and parents of the children that we're working with. There was a longer MLU in daily interactions, not just with his therapist, improved self-confidence to speak, fewer repetitions to help others understand him. Family and caretakers could better cue him for clarity when needed, and simple cueing of loudness allowed him to concentrate on what he was saying instead of how to say it. So really keeping that cue simple was key. Now, in the next slide, we see here, it shows that the research that has examined LSVT loud applied to children since then has primarily been focused in the area of CP and Downs. And you can see, or you can kind of dig into the research and the details of these studies here if you scan the QR code to be able to look into those studies if you're really interested in those details. But what's nice is that there are so many clinicians trying to use the program with individuals they think might benefit. And this is one example of a publication of a case that was published as a brief report, including a child with autism who completed the LSVT LOUD program. Now, this case was really interesting, mainly because when we first evaluated this child, he was not a candidate for the program. But I trialed an individually designed pre-treatment protocol that really prepared him to be able to fully participate. So let's talk a little bit about that now. Now, at the time this person was finally able to participate in and complete LSVT LOUD, he was 18, but we began therapy with him when he was 16 and a half. So he had a diagnosis of autism spectrum disorder. There were present cognitive, speech, and language disorders, a fluency disorder, diagnosed dysarthria, and childhood apraxia of speech. He was not medicated, and parent-reported speech and voice concerns included weak breath control, reduced loudness, very limited clarity when attempting to speak, not having enough breath, soft or hypophonic speech, monotone, and no confidence with speaking. So at that point, I moved forward with an assessment and conducted stimulability testing for LSVT LOUD at that time. But assessment results revealed that the child was not initially stimulable for LSVT LOUD. There were several negative prognostic variables. The child was not able to respond to cues or models to increase loudness. The age at the time of the assessment, 16 years, made the prognosis guarded. Cognitive, speech, and language disorders were present and quite significant, though AAC was being used, and that was a positive variable. There were lots of behavioral problems as well, though this person did have a behaviorist and someone who worked with him each day, and so that was quite helpful. Other positive prognostic variables included the client and the parent level of motivation to attempt to acquire any kind of functional verbal communication. They were so motivated, they really wanted to try it. They were so hopeful. And so they were open to a trial week of treatment to determine candidacy and feasibility. And fortunately, that behavioral therapist was available to co-treat. So based on the results of the assessment and stimulability testing, I designed an individualized pre-treatment protocol to first establish a response to multisensory models with faded cueing. So that took about 6 months. What we first did was train volitional inhalation and exhalation using tactile cues, using visual models. We essentially pulled out all the stops to be able to help that person or child respond to the techniques, to the models, to the cues, multimodally, to be able to learn how to volitionally take that deep breath in and then exhale, and then deepen that, both that inhalation and that sustained exhalation over time. Once the child was able to take that deep breath in and sustain that exhalation, we then paired that sustained exhalation with phonation, resulting in daily exercise 1. So he started to be able to do that loud, long ah exercise required within the first exercise of the program. Over time, we built a tolerance for repetitive practice and established behavioral supports to allow the child to succeed and stay motivated throughout these intensive sessions. So the first session is going to be played in a video here. This was at the very beginning of treatment when the child was just learning to perform the daily exercise. And so this was the loud, long ah. We were actually just practicing in the park. And this was building his strength and endurance to be able to participate in the LSVT LOUD program. What you're going to see is the behaviorist will take his hand and guide it over a piece of paper that you don't see on the table that has a line on it. And so the child's following that line to be able to provide him with a cue to sustain that voiced exhalation or that voice on the ah sound. So let's take a look. One, two. So that was a really great start to that first exercise. He was able to breathe in. That was me taking a deep breath in to try to cue him to take a deeper breath in. And he was able to produce voice on sustained exhalation for a short period of time. So once he could handle that, we then moved on to stage 2. And in this stage, I needed the child to acquire the stamina to complete 2 of the daily exercises targeted within the LSVT LOUD program. So we stabilized that normally loud phonation. We extended that loud phonation. And then we started to teach pitch manipulation, which is needed for daily exercise number 2. Now, after that, we moved on to the next 6 months of the pre-treatment protocol. And in this stage, I helped him establish competency in performing all aspects of LSVT LOUD within 1 hour. So we needed to be able to complete the required number of repetitions within each exercise in the time allotted, and also have enough time for the hierarchy practice, which is the part of treatment that helps the child bring that more coordinated speech motor pattern into functional communication. So we developed endurance for functional phrases that this child said every day to really facilitate that calibration and generalization. And then we implemented scaled up normal loudness levels in these hierarchical language exercises. And then we finally made it. After that pre-treatment protocol, we were able to administer LSVT LOUD per the gold standard delivery. Now, we noted significant gains made across several perceptual and acoustic measures during performance tasks, such as maximum phonation time, speech loudness, and speech intelligibility. There was variability due to behavior and language abilities, but improvements were maintained at the five-month time point. Previous disfluencies, interestingly enough, that contribute to unintelligibility in the beginning of the program were absent during post-testing and follow-up sessions. So let's take a look at a video clip of the child performing the same ah exercise, that first loud long exercise within the formal LSVT LOUD intensive program. What a difference. And now in this next video, we're going to see this child producing some functional phrases, really bringing that loudness that he gained in the ah into his functional speech exercises. And I hope you're going to hear a nice improvement in articulation or that spreading of effect to intelligibility and into functional speech.
Oh, how are you?
I love.
Good job, Joe. Goodbye. Take care.
Goodbye, take care.
Excellent. Nice and loud. Think shout. Thank you very much.
Thank you very much.
Good. Watch me, Joe. Thank you very much.
Thank you very much.
Good. Keep it loud. You focus on me?
Yeah.
Excuse me, please.
Excuse me, please.
Nice job, Joe. Hi, Mom. I love you.
Hi, Mom. I love you.
Good job. What are you doing?
What are you doing? doing?
Good job, Joe. Yes, please.
Yes.
What's going on?
What's going on?
Nice and loud, Joe.
Keep it loud.
What's going on?
What's going on?
Why? Again.
Where are we going?
Good, but even louder. Let's go back to why. Say why.
Why?
That's it. Where are we going?
Where are we going?
Good job.
Wow, that was clear.
So, what a great result. And what we noted after the program was that several adaptations to accommodate difficulties with behavior were needed to accommodate those speech and language disorders, and that made it possible to administer LSVT LOUD while maintaining treatment fidelity. So we did things like had breaks in motor practice. Sometimes we needed longer sessions. We definitely needed some additional weeks of treatment, as well as behavior management. There were modifications made for language levels and reading levels. And of course, additional feedback, reinforcement, and counseling were needed to increase confidence as a speaker. But these findings really provided some exciting and preliminary support for the intensive voice treatment to improve select aspects of voice and speech functioning in this population. Now, as more and more clinicians become certified in LSVT LOUD for kids, I'm hearing from more and more clinicians around the country about their success in using LSVT LOUD with a wide variety of populations. And if you are ever presented with a case that does not yet have supporting research, this is a really nice way to determine candidacy. Remember that your ultimate decision about whether or not to use the program is based on your assessment results, the response to stimulability testing, and your clinical decision-making. And if you're thinking it might work, then I would recommend moving forward with a trial week of LSVT LOUD. First, you'll try 4 consecutive initial sessions and evaluate the impact, then monitor progress and treatment along the way. Of course, you can easily quantify treatment changes. And then if things are going well and the results are showing a kind of positive direction or positive change, then go ahead and proceed to deliver LSVT LOUD per that gold standard protocol. And then ask yourself these questions along the way. And know that if you are unable to answer these questions yourself, you have a wealth of information available to you in your clinician account. You'll always have access to the LSVT LOUD experts, both online, via phone, and through office hours that are offered every single month. Now, I want to end this lecture today with an LSVT big pediatric case example. She's a 10-year-old diagnosed with a grade 3 brain cancer or tumor 5 years prior to receiving LSVT big. The tumor extended from the 4th ventricle into the cerebellum. She had a history of 3 open brain surgeries for tumor removal and 50 doses of targeted radiation. This child was such a strong kiddo. And I want you to see a couple of videos of her participating in LSVT big, because these results are very exciting. Now, in the first video on the left, you're going to see her sit to stand. On the left side, you'll see her before LSVT big, and on the right side, you'll see her after. Just amazing. And in this second video, you're going to see her after LSVT after LSVT big in a floor to stand exercise that was a big improvement after that 16 sessions of treatment.
Ready, set, go.
So she had improved and was able to stand up from the floor in 2 seconds, and that was a 5-second improvement from the time of the assessment.
Ready?
And so I hope these latest and greatest results and information, this exciting news has showed you that scientific discoveries must be translated into clinical practice to benefit humanity. And these are inspired by patients and driven by science. Thank you so much for participating in this lecture. If you have any questions, don't hesitate to reach out to lsvtglobal.com, call us, or email us anytime.